And now we have our last speaker, Dr. Krishna Prasad KUDLU. He is the chairman for editor proceedings of All India Ophthalmic Society, a terrific trainer, owner of chain of hospitals in South Karnataka, and he is a certified smile and a phaco trainer also. So over to you, Dr. KUDLU, to give your talk.
Thank you, Amit, for including me in such a wonderful IC. I think morning 8 o'clock was a very good audience. I think thanks all the audience to be part of this wonderful IC. So the last part of this IC is if the Rhexis extension problem, how I deal with it. Excuse me, can anyone help audio visual? Slides are not moving. Anybody from audio visual, please?
So I think meanwhile, till it starts, I think if you observe, ma'am, when the lens is rotating, it's extremely difficult to do a vertical chop. Very, very difficult. But you should, if you observe her technique, once you've got a good hold of the lens, the dialer or the chopper should be just in front of the tip. That is very, very crucial. Normal tendency is to go too much ahead and try to chop. So that's when the lens rotates and it's like tearing a piece of paper. You hold it very close, it's very easy to tear. But if you hold it further apart, it's very difficult to tear it. Sorry. So you have to place the tip just in front. Thank you.
Sorry, Naren. So just to those who are starting, a few of the postgraduate students are here. In the 1984, Gimbel for the first time introduced this continuous capsulotomy. Then followed by 1986, our senior surgeon from Japan, he called it, Shimizu, called it as a circular capsulotomy. So what should be an ideal capsular Rhexis? It's a circular opening made in the entry capsule of the eye during the cataract surgery. The goal should be create a smooth, round and appropriately sized opening to facilitate the removal of the cataract and proper placement of the intraocular lens. So what should be the good Rhexis? It should be round, size should be around 5 to 5.5 and it should be well centered on the visual axis of the eye. It should be smooth and well defined edges. This is very important. That helps in prevent potential complications such as lens displacement or PCO formation. And also there should be adequate overlap. Capsular Rhexis should have a slight overlap around the IOL haptic. Then you make sure that there is no tears or irregularities. So what are the advantages of capsular Rhexis? Capsule can be stretched, hydrodissection is safe, phaco can be done very comfortably, easier cortical aspiration, and IOL can be positioned safely and placed on the Rhexis in the case where there is a PC rupture. So why surgical dilemma? See, you could be able to see there is already Rhexis has been torn, so the manipulation is going to be much, much difficult. So I will be telling you in the coming slides how exactly you have to manage. So what are the challenges in a compromised Rhexis? There is a risk of capsular rupture tear in a compromised capsule can lead to high risk of tear during the phaco emulsification. Difficulty with the lens support. The compromised capsule may make it difficult to properly to center and stabilize the intraocular lens. Of course, posterocapsular integrity is very important. Now coming to the how to assess the extent of the tear. Suppose if you are having a very small tear, then it can be managed by continuing the phaco emulsification. If the tear is large, then it should be more careful assessment is required. It might affect the ability to place the IOL in the bag also, very, very difficult. So this is the one small little maneuver for the Rhexis run out. So when you see here, always you should pull this away towards you. Then sometimes wherever it is able to run out, you may not end up within them. You will end up in a complete capsular Rhexis. This is the one thing I have taken from, which is described by our great friend Dr. Rohit Om Prakash. This is about the flap motility sign. Always you should look for the flap motility sign. This is very important. If the flap motility sign is towards you, that means the Rhexis, this kind of extension is not going to trouble you while doing the phaco emulsification. This is very, very important. So always you should look for the flap motility sign. So coming to the once there is already the Rhexis has been extended. The maintaining the chamber stability is very, very important by injecting high molecular viscoelastic like Helon or Viscoat, and don't do a very aggressive hydrodissection. So careful hydrodissection is very, very important, and make sure that the nucleus will not be come out. Then again, this is plus or minus. If the tear is very small, or if you think that okay, the whole bag is unstable, even though it's contraindicated, sometimes in some of the cases I still used a capsular tension ring. But again, it's plus or minus, you have to assess on the table. So surgical techniques and AIOS, first aim whenever there is an extension of the Rhexis, then always you should relieve the pressure on the eye. Second one, careful irrigation and aspiration. Special care is needed when irrigating and aspirating the lens matter from the antechamber. Then suppose if it is rent happened, you need to do a proper vitrectomy. So coming to the lens removal, if the tear is minor, the capsule bag remains intact enough to hold the phacoemulsification, still can be proceeded. But if it is tear extended beyond, can get sometimes, this is the one technique, you can get the pieces into the antechamber under cover of high molecular viscoelastic, then slow phaco can be continued. So this is a video where we can see extension already, there is a grade 4 nucleus sitting inside. So you have to assess the case first, then see that, see for the flap motility sign, this is very, very important. If you can see this flap motility sign, then you can go ahead with the slow motion phaco, even there is a grade 4 cataract. So surgical technique, this is also important. There are few of the videos I have taken from Dr. Rohit. So calibrated incision is also important. Then make sure that fluidics always will be there in your control. As I said, that slow motion phaco is very, very important. So this should be the surgical technique by doing that, so that the each pieces will come till the tip. Suppose if you keep these high settings, then the lot of fluid will gush, then finally the tear will extend beyond, then there is a chances of even PC tear, then followed by nucleus drop also going to be there. So these are the advantage if you keep with the low settings, so that there is no question of this capsular tear to extend, and you can continue with the phacoemulsification. So low IOP phacoemulsification, as I said, very important. Of course, site of the incision in relevance to the axis tear is also important. Sometimes you can even do creating an additional Rhexis extension, but very important, no pushing of nucleus while trenching. Avoidance of wide separational forces, that is very, very important. Try to separate slowly, don't put lot of pressure, so that then again it will extend. Separation force in the direction of the tear, that is very, very important, and I prefer to do a supracapsular emulsification. This is a case of, already madam had showed how difficult it is to manage this kind of, see the surgeon suddenly took the mind off, then he could able to see the Rhexis has been extended. So always prefer to do with the forceps. So coming to the intraocular lens IOL management, of course if the tear is small, in the bag IOL placement is, you can place it. Suppose if you think that already the tear is extended, you can place the intraocular lens in the sulcus. Of course, whenever there is a severe rupture, I think you need to plan for secondary IOL. So handling proper posterior capsule and vitreous important. So if the posterior capsule is torn, vitreous prolapse may occur, then plan for a good anterior vitrectomy. Preventing posterior capsule rupture, if there is a risk of posterior rupture, may need to modify their technique, proceeding with the extra caution during the lens removal. So option for conversion, endpoint of the safe phacoemulsification. If the surgeon is not comfortable, there is option of conversion is there. So no panic mode, evaluate extension of the tear. Very important, flap motility sign, adopt safe phacoemulsification technique. Suppose if not possible, how Haripriya madam said, you can convert into SICS. So these are the management strategy. Very important, early identification, refill the antechamber with the, preferably with the high molecular viscoelastic. Keeping the capsular flap flat, this is very important. Keeping the capsular flap flat, use always forceps whenever there is extension. Direction of the pull is centripetal, very, very important. So take home message, proper management is essential for preventing further complication, including extension to the posterior capsule, vitreous loss, dropped fragments and IOL dislocation. Perform hydrodissection or viscodissection after the central debulking of the nucleus in order to reduce the stress on the capsule. Before irrigating the instrument from the eye, refill the antechamber with the OVDs to prevent collapse and subsequent stress on the capsule. Never insert a CTR before completing the capsular Rhexis, as expansile, it gives more pressure on the capsule. Proper subsequent follow-up. Thank you one and all for the kind listening. Thank you.
Wonderful presentations, Dr. KUDLU. So I had one question. I mean, do you use anything specific, viscoelastics in intermittent cataracts? Anything specific, sir, or just a HPMC, or what do you use, sir, to prevent the viscoelastics?
Viscoelastic, initially I use only HPMC. But nowadays I started doing with what Kamal Kapoor always advised me. Just go with the 26 gauge needle, try to suck it off. But sometimes inside the pressure will be so much. Sometimes when you give the nick only, it will extend. But if you could able to take out all the fluid out, then you can get any kind of Rhexis. Normally I try to do a small Rhexis whenever there is a hypermature or intumescent cataract. Try to do a very small Rhexis. Then once the fluid comes out, then I will do something called a double Rhexis, make it around 5.5.
Do you use any cohesive, sir? For
Initially I use HPMC. Then once it is, then I followed by the cohesive.
Okay. Any other questions, sir?
I'd just like to.
Yes, sir. Please.
Yeah. See, I showed you one video. See, suppose whenever there is extension, if you think that it is extended like this, that means that extension might have extended beyond. But if you see that, you could able to see that flap which is coming towards the centripetal, then that means it is not been still extended till the beyond. Then you can still go ahead with the phaco. This is the flap motility sign. If you can see, I am not praying that your 60 should not extend, but whenever there is extend, you put the viscoelastic, then see that how this flap, wherever extended, it behaves. If it is towards the center, that means it has not been extended.
An important dictum here is, if the tip of the flap, the conical part or the cut edge of the point is folding inwards, it is more so a safer tear. And if it is folding outwards, means towards the limbal side, it is everted the tip of the flap. It is more chance of it extending onto the posterior capsule. The house is open for questions.
Still 3 minutes.
We have to leave the podium in time.
Also, it's 3 minutes.
Yeah.
Any other questions from the audience? So one more technique, let's say in hard cataracts. Now, if you think about it, see, we have always been told, okay, look, hard cataracts, we need to chop very deep and then try to separate, right? But technically, if you think about the lens, it's like an onion. You got these different layers, right, from outer to inner. So that means the most superficial layers are attached to the posterior plate, right? Now, in hard cataract, what we want to do mainly is to separate the posterior plate. That's the whole point. And the hardest part is in the center. So in hard cataracts, I personally, how I do is, I mean, everyone has their own techniques, but I never do a deep chop. I do a more of a superficial chop and start separating the fibers. Now, I'm not worried of separating the central nucleus, which is the hardest part, so I leave it alone. So I start separating it, so what it goes along, once I start separating from the center, it goes to the equator, separates and comes to the posterior plate. So I have separated the posterior plate without even touching the hard center nucleus. So that makes chopping so much more easier in these hard cases. And once you finish, then the central nucleus will be separate. Then you can eat it up and then finish piece by piece. And the reverse is a soft cataract. Soft cataract, you want to hold you have to identify where the hardest part is. Obviously, it's in the center. So you have to do a deep chops. Deep chops in soft cataracts. superficial chops in hard cataracts and deep chops in soft cataracts. So that is a small tip which all of us can try.
Excellent presentation, excellent videos. I'm sure there are a lot of very, very experienced surgeons on the dais and amongst us. But there must be some people who are learning also who have come to attend this course. I just like to add one thing which I felt would be a safe way to go for people who are learning, who are graduating from NS2, NS3 to this hard brown black which we are demonstrating. After we've done all the chops or made all those segments which we have, to replace that very sharp or very long chopper with something which is slightly shorter, maybe a Sinsky hook or a smaller chopper, so it's safe. Because they've done most of the hard work by separating all the segments, so it will be nice to have a safer instrument because you know where exactly you can move it around more than a larger instrument inside there. Just a suggestion for people who are graduating from.
Yes, sounds good, sir. Sounds good. Thank you so much, everyone. I think ma'am wants to.
Now, just talking about beginners, I just said that I learned Phaco Chop from Dr. David Chang's book called Phaco Chop. So for those who are beginning, I would recommend that book very strongly. I think I was fortunate to observe him once. And on the way back home, I read the book and that's where I learned how to do it. So if for someone who's starting off, that's a good place to start, is to get the book called Phaco Chop by Dr. David Chang. So thank you again for all being here in this morning session.
Thank you very much.
Thank you.